I guess the difficulty there is, the old patient that sort of, I want this done yesterday. So I think it's important to mention that at the start, that we can't control certain aspects.
You've got to explain that to the patient, right? And then if it's not stable, then they're wasting their time and their money.
Thank you.
Very good point. Thank you, Stan. Appreciate that. I think that's important.
Dr. Sarkis, can I ask a question?
Sure.
In the initial stages of this patient, I assume you will be doing a occlusal interference, whether that's causing the wear?
Let's go back.
Hmm?
Okay, what you're saying is occlusion interference. Something causing a wear.
It's an over-eruption of, not in this case, but say upper eights or the eights coming and causing this open back?
Let me have a look. No, there's no eruption of teeth here, as you can see. I know what you're saying, and I accept that.
And not particularly this case, but if we see a case, is that one of the things we should be focusing on?
Okay. Look, I'm happy to share another slide with you to explain you, for instance, how occlusal trauma with the anterior shift of the mandibles. I think that's what you're saying. There's a posterior overruption of the mandibles coming forward and it's creating weight. Is that what you'd be implying? Is that correct?
That's correct. Well, the possibility of that.
Look, let me just I'm just trying to think. I'm happy to show you a case where that's the case. It's very rare. Usually it's on the second molars. Usually the patient loses a sixth and the second molar rips forward, okay? And so patients trying to come forward, there's an interference that slides off that, right? And the mandible comes forward. There are instances where this can happen naturally, but in this particular case, that was not the situation. It's basically with time, there's a bruxa with a wear pattern and with the mesial migration of the force, the mesial vector force, basically created low crowding. Also, there's a change in whole skeletal changes in this case. So occlusion is not the only factor. It's only specific areas where occlusion plays a part, and I accept that, especially with mesially inclined. Let's say if you lost a molar, nothing goes down, the seventh drift mesially forward, and so there's an interference, and it comes forward to be able to bypass the interference here. Yeah, that's a possibility, but that would be something that I would say is a causal factor in this particular situation. And what I will do in that situation, I will basically refine the occlusion. I will actually build the occlusion. So I will refine it. I will add some composites and stabilize that tooth. So in other words, so when there's a binding together, that tooth is actually quite stable. And I will use the opportunity the other way, so you can do some composite build-ups, or if you've got plenty of memory, you can do some occlusion refinements. Naturally, you want to do that on a model. For instance, a lot of the times we have this printed model. Okay, so a lot of my models, I don't take impression, I actually scan them, and I print them, then I mount them on the articulator. So the beautiful thing about these models is they don't break, which is beautiful. So that, and you get a very accurate reproduction of the actual dentition with the digital scanning. So I do it all the time. Sometimes I get busy, I get my laboratory mounted for me. So all my models that I do are also, now there's no more plaster. I mean, Isidoro is a master of this. He's got a whole factor of printing models. Even doing some of the complex prosthodontic cases where the half the maxilla is missing, for instance, you'd be surprised how accurate the reproduction of this is. I think there's a marvel part of digital dentistry that you can use in your surgeries and improve your diagnostic outcome and also improve your assessment. So that's something I do now every day. We do teachers in the college. We tell you all about how to think and how to integrate all this new technology in your practice. This is really important part of the next stage, I think, in dental education.
So the wear in this case is more to do with anterior bruxism. Is that right?
The patient's anterior bruxa, but you see what happens is if you think that occlusion is causing bruxism, there's no such thing. Okay, that's been dead, buried, and bolted down like a nuclear reactor. the bruxism is parasomnia is a part of many other symptoms or signs or disease that actually participate in bruxism. It's a sleep disorder that could be caused by a number of factors. We don't really know what causes bruxism, other than saying it's a sleep disorder. Nighttime bruxism is more of a sleep disorder, but as a daytime bruxism, awake bruxism is more of a stress-related, more common in children, and that goes on to the adults as well. So if you want to know more about bruxism, I'll have to send you some references. They've graded bruxism into different grades, and I'm happy to send you my references. You can talk about it a bit more. So it's not caused by occlusional interferences, bruxism. There's no real such thing. As a matter of fact, if there's an occlusional interference, people actually don't brux because it's painful, so they'll stop. There's a lot of studies by Carlson and the early chaps in the 1967 up to 1997. Japanese have done a lot of studies, and there's no real relationship between, there's a causal factor of occlusional interference and bruxism. That's just been dead and buried. There are so-called gnaphologists who bring this concept really high up to say, occlusion will, good occlusion and good TMJ are perfect for optimal function of the stomatognathing system, but there's no relation, because one thing that the gnaphologists and all the gnathologist societies didn't take into account that the temporomandibular joints in the mouth is constantly remodeling. They're not made of steel. If the joints are made of steel, I absolutely agree that your occlusion had to be perfect like a machine parts, but it's not. Porcelain did studies in 2000 and 2002 where he said if you got obliterative mounting, a simple face bow, an articulator, that's all you need. You don't need to have a fully adjusted articulator. The difference in the mold is like 0.2 millimeters by opening up to about 3, I think, or 4 millimeters in the size if you run open and bite, etc. So we've gone past that. The old articulators, those fully adjusted articulators, are no longer sort of, really considered. But there are people who still use them because it reduces your clinical time. There's nothing wrong if you use them. But I'm happy to use a semi-adjusted articulator, and it's an Archon or non-Archon. So this one's a non-Archon. In other words, the condyle is on sorry about this. Actually, this is Archon, so the condyle is moving, but there's a non-Archon one where there's a condyles on top. So it doesn't matter which way you look at it, still does the same thing. And as long as you're using a semi-adjusted articulator, mount your mirror models, adjust them on the models, and then you'll be able to get the, and then you can take a pull down, clear pull down, and you take it to the patient, and you can mark on the model where it is, and on the clear pull down, you just place on the original model, you just remove the interference on the model. So you have your formula, you transfer the patient's mouth, you just go to the high speed, stop, and you adjust the occlusion. But you have to discuss this with the patient. The patient has to know exactly what you're doing, because your patient has got a occlusional hypervigilance. When you touch the bite, that's it. You will never have the end of the case. They'll be coming back all the time. I have 3 patients like that has been unnecessarily adjusted by other colleagues, unfortunately. They're in a hypervigilant phase, so they can't accept the fact that it's always hammering the brain. In other words, that whole sensory area keeps firing into their cortex through the, caudalis, right through up the cortex, and the sensation sometimes becomes pain, and sometimes can turn into neuropathic type of pain. So you have to be very careful how you treat those patients. So patients looking up, I heard the feeling is really, really high, and think before you start adjusting teeth for that reason. Okay. I hope I was able to answer your question.
Sure. Thanks.
Pleasure. Any other questions?
Sorry, one more question. Would you prescribe canine guidance when you in your restorative?
Okay, there's no data that says canine guidance is better than any other guidance. Now here's the issue. Canine guidance is easy to make. It's easy to create. Okay, it's also more anterior in the arch. So there's less forces on canine. Plus, the canine tooth is ideally positioned for a guidance. okay? It's got a very strong, thick labial cortex. It's a long root. It's very thick buccolingually. It's got lots of enamel, so it's very strong tooth, okay? So when I'm doing reconstructive work, I like to have stops on the canine cingulum area. I will reconstruct stops. And that's important to me because I like to get some sort of freedom and pick up the canine guidance. So at the end of the day, I know that with having canine guidance, people feel better. Also, there's some studies show it's better for the joint, but basically it's easier to achieve. It's more anterior and there's less forces. So as you go to the side, you're grinding on canine, the force, if you're grinding on the canine, you're pushing hard. Which area is the force transmitted? Usually it's not this side, okay? You're really hard, it's actually the other side, okay? So if you have a patient comes in temporomandibular joint and I want to do a provocative test, I know which way to press to find out where the pain is, okay? That tells me there's a pain is intracapsular, extracapsular, where it's related to the muscle pain, so there's all sorts of tests. So canine guidance is ideal guidance to have that facilitates restorative outcome. Am I making sense?
Yes.
All right. Now, you know, and if you have a deep bite, there's no relation between bite and temporomandibular dysfunction. Now, only the Americans love that stuff. You understand what I'm saying? Only Americans like to say, certain parts of American schools, where the gnathology is still taught, where there's a set, I would say, recipe for everything. And unfortunately, you need to think of every case as an individual. And when I discuss saying, what is your occlusional prescription, I need to know where is your end point of the occlusion that you want to achieve to improve your restorative outcome. Okay? Your clinical outcome. It's not a guessing game. You have to know where you are going.
So can I ask, in that case that you just showed to us, Sarkis, where actually did you go with the occlusion? You added obviously some
I built the occlusion from canine, ramp,
Yep.
lateral ramp, central ramp, okay? So patient was biting with his teeth from canine to canine, okay? And he was comfortable, felt a bit uncomfortable, said, look, and with time, the posterior teeth and some on top of that just came down and met. Now, Dahl showed in 1975, it was a one case clinical study, but later on until about 1996, even then, more studies have come in and proved it. You get about, the posterior teeth are up by good 2 millimeters. This is orthotic movement, just like when you have a binary or a twin block, it's the same concept. Do you understand? We just use it prosthodontics. And in those days, because there are the VMKs, there was zinc phosphate, he needed more crown to be able to prepare, more core, to be able to have a resistance and retention form to the crowns. Okay? And that was the way you could open the bite, create restored space to be able to restore the teeth.
So with your build-up, you actually reduced that protrusion problem that you had without building up. Is that right? Basically, did you take it all away?
Create guidance, yeah, because I opened the bite, I created my restorative where I want to restore my prescription. Okay, so he will able to come forward. Okay, when he goes sideways with the canines, and you have a composite build-up. Okay, you know the composites are not as strong as porcelain to resist strong lateral or anterior forces. So you design your restoration, so you share the guidance. As anteriorly, I'll share the front four incisors. On sideways, I will probably share the lateral and the canine. It doesn't matter. It's not a canine guidance per se. If you have a class 2 div 2, how are you going to get a canine guidance? You're going to have a premolar guidance most of the time. It usually is group function with canine and premolar. There's no such thing that which is ideal. Okay? Whereas if you do orthotic treatment, not every case is to be finished in class 1 case. That doesn't have to be.
So basically, for the Dahl concept, you had contact from 3 to 3 built up on the palatal side of the upper anterior teeth.
Yeah, and then posterior tip erupt.
Okay. And how long do you expect those composites to last? Like 5 to 7 years as normal? And would you replace them later on?
Yeah, we can add on. I mean, you can easily add on composites. So just sandblast, add some bond. Where you go? I'll etch because there's a residual enamel. I'll build onto it. I've died on this. It's not an issue. This is a very common treatment modality in Europe. I mean, especially in UK. It's very common. I mean, I like the conservative nature of most of these treatments. I know if there's an American school of Boston, they probably or something like that, they will cut down those teeth, all the upper centrals and lower anteriors, just to be able to create all the ideal stains. It's not necessary. It's just not. You should always look at the simpler options for the patient.
And in this case, you use composite, but you could obviously use porcelain if you want.
You can easily use porcelain. You can use mineral prep porcelain. I wouldn't go all the way up. I can finish. Let me come back to this side. I can finish. See, my composite is finished about here. Can you see it? It's about there. Okay. This one's probably about there. All right. This one's about there. This one's about here. So if I'm doing porcelain, I would not go all the way up there. I just finish about here. I can blend any porcelain in the middle of the tube because I know how to do it. And we teach that in college too. Okay? You don't have to have the porcelain finishing all the way to the margin of the hymen. Okay? You don't have to do it. It's how you do it, that's the key. It's how you design your margin, the key. And the work's done without injection. Okay. Wait till next year. College is coming next year. We're going to start soon. When I put out the communique, do come in because it's a very, very good concept of good teaching. So in many ways, it's single layer. You have those images of people putting 50 layers and building up and all that. I can tell you one thing. I hardly do that. I don't see the point. Stan, any comments from your end?
Not from a restorative. No.
He will come and see you for the CT graft in this area. So he's becoming more aware of the situation. People become more safely aware, so you explain to them. But you got to point all this out before you start the treatment.
Hi, Dr. Sakis. Thank you so much for tonight. Just in regards to the DAL principle, do you often do it on posterior? I know one of the things that's recommended is only if you see it on anterior wear with not much posterior wear. How do you find that? Do you do cases sometimes? Just because I noticed this gentleman was a little bit older, so I'm assuming he would have a little bit of posterior wear as well. Do you find that there are any problems with that, doing the DAL principle on cases with a bit of posterior wear, or not really? Good
question. Actually, a very good question. I did one today where my patient, I had placed porcelain veneers for a long time for the upper arch and also for all the lower arch, and porcelain in premolar, the premolar and upper arch, molar to molar. And she came with time, there was a wear, and she chipped around the porcelain veneers on 4-2. So when I looked very, very carefully, I realized that bite had closed so that you couldn't repair it. The only way to repair it, you had to either replace and cut the tooth more. But she also said she'd like to consider having a new set of porcelain veneers. So here's was an opportunity. She also had posterior teeth unrestored, had some occlusional decay. So there was no room because of the posterior eruption or somewhere. So I removed the decay and restored them and placed a platform on 2 molars, the 6 and 7s bilaterally. So I gave her a platform, and you balance that platform. I said, look, you might feel uncomfortable, but next couple of weeks you'll find your bite will be fine. So what I do in that case, rather than drilling out the cavity more to the restore, and that's unnecessary tooth invasion if you allow optimal thickness of the restorative material for proper strength, etc. So I will put a build up on the tooth, remove the decay, allow the build up, and that's basically sinks into the bone. It's just intrudes, just like any orthodontic intrusion. This is an orthodontic movement, okay, basically. So in that way, you have an optimal tooth position and a good restorative height and natural properties that you're able to do. So good question. Yes, you can, provided there's no TMD. Okay. Now again, if the patient has TMD, you might find that it actually sometimes helps as well, okay? Because it changes the whole sensory mechanism. So not because bite and TMD are related, but if you have to restore, provided you explain to the patient, okay, you might want to do this with a, look, people say you have to do a temporary appliance, use a splint, see how it goes. I think simple build-up is not a major issue, okay? So I don't have a problem doing a build-up, tooth intrusion, and then if there's some contacts, then I have an anterior opening from premolar to premolar, so I can place new veneers with minimal, without invading further tooth structure. So it's quite common. Yes, I do. So dialog is a very important part of my armamentarium as I treat complex cases and simplify. Any other questions I can help you with? Good questions so far, I can tell you. All good? Well, Stan, thank you so much for joining us.
You're welcome.
I hope to have you join us again.
Will do.
Thank you. Thank you, Izzy, Jennifer, Virginia, Mr. Prudential Dental Clinic. I love it. Keep asking those questions.
Thank you.
Thank you all.
Thank you. Good
Thank
night.
you.
Good night. Good night,
Thank you.
everyone. See you.
Thank you,
Bye.
Doc.
Thank you. Goodbye.
Thanks.
Bye.
Bye-bye.
Good night.
Bye.
Good night.
Thank you. Bye.
Thank you.